So the background is small molecules, rapidly diffused everywhere that there's PSMA, generally don't cause too many problems, but because they're getting into areas that's PSMA but not cancer, there's some dry mouth and other issues, but the betas are not so strong, so it's mild dry mouth and they tend to get better. We actually happen to present some patient-reported outcomes with one of those therapies, and overall it was favorable. So those low-grade toxicities didn't translate into a decline in patient-reported outcomes. Using the same carrier, small molecules, with an alpha emitter, even though they haven't really been prospective trials, might lead to more damage, and we know, at least anecdotally, that there can be severe damage to the salivary glands with kind of the most extreme cases, loss of taste, loss of teeth, presumably a poor quality of life that goes with that. So this trial, getting to this actual trial, used a powerful alpha emitter, 225 actinium, or actinium-225, but used an antibody rather than a small molecule to take it to the PSMA-positive cancer cells and avoid the kidney, bowel, and salivary glands. Because it's essentially the first time, even though we've used the antibody with a beta emitter, it's the first time that we've used an alpha emitter, so we did a dose escalation study where we started slow and then went up. We planned on 7 different dose levels. We kind of predicted, based on dosimetry with the antibody, that the 5th dose level was where we're going to probably start seeing some toxicity, so we planned on 7. But that was all based on historic information. So what happened is we ended up proceeding, the final results, we proceeded to dose level 7, did not have a dose-limiting toxicity in the 6 patients at that dose level, and just stopped. And that's the planned single-dosed level that we'll plan for future studies, with the plan for multiple doses as well as combinations.